Healthcare reform. It's a battle in Washington and a debate nationwide.
President Obama signed a healthcare law in 2010. You might know the Affordable Care Act by its more common name, Obamacare.
The law wants to provide all Americans with affordable quality health care, and if you don't register for health insurance by the end of March, you will face tax penalties.
Obamacare also affects college students. Anyone under 26 years old can stay on their parents' insurance even if they don't live at home.
But not everyone is excited about the Affordable Care Act. On one side, you have those saying healthcare is a private matter and the federal government should not be involved.
But those on the other side of the debate say it is the government's responsibility to guarantee health care for all Americans.
And now the healthcare law faces bigger backlash after many Americans are having trouble logging on to the healthcare.gov website, a portal to the Obamacare insurance marketplace.
Thank you, Dr. Gaither. Good evening, everybody. My name is Ginette Archinal. I'm a board-certified family practice doctor. Currently, I work as the University Physician and Medical Director of Student Health here at Elon University in partnership with Alamance Regional Medical Center, so I'm actually employed by the hospital system. I attended, well, before I moved here, I actually was in private practice in Cary for 10 years. So I've experienced both private practice and employed healthcare here in the US. I grew up in Sydney, Australia, and attended medical school there. In the Australian system, I mostly worked in hospitals during my residency. After leaving Australia, I moved to London in the United Kingdom, worked in hospitals there, worked in private practice there, and also worked in community health centres in Britain, mostly in paediatrics. All my work in the United Kingdom was working for the National Health Service. In the United States, I attended residency program at Emory in Atlanta, so worked in the hospitals there. Moved to North Carolina to be an employed physician with Duke University Medical Center. Opened my own private practice, and now, of course, I've worked for Alamance Regional Medical Center in their practices here, and now in student health. So basically, I've worked in 3 major healthcare systems in the Western world, and I've provided healthcare in those systems, but I've also received healthcare in those systems. And I guess the one thing that I really do know from all 3 systems is that nobody knows how to deliver the healthcare that everybody wants to keep everybody happy all of the time. There is no perfect healthcare system. The other thing that I think has been interesting is that in each system I lived and worked in, the healthcare system changed in the periods I was living and working in each of them, which just goes to show that even the countries that have a system know they're not perfect, and we're constantly trying to change. And I think that's something that's really important right now, as we're in this intense period of change in healthcare in the US. Is no matter what comes out now or next year, it will be different 3 years from now, 4 years from now, 10 years from now. And I think we need to bear that in mind as we think about what we think is important in healthcare and what changes are actually being made. None of this is fixed in stone. My personal point of view about healthcare is that we have a moral responsibility to provide affordable, basic health care to everybody in our society. We are a first world country here in the US, and I find it morally reprehensible that so much of our society does not have access to basic health care. Also, from a purely economic standpoint, taking aside my personal ethics or sense of morality, we need to provide affordable basic health care to everybody to keep society functioning. I mean, we don't argue about providing basic education affordably to everybody in society because we know that that's required to keep our society functioning effectively. But if we don't provide the health care at the same time, then the education basically can be wasted. I think that we're tackling healthcare reform without really thinking things like this through. Healthcare should be a right, not a privilege, and we need to stop thinking about it in terms of rights and privileges. And I'm taking too much time, I can tell. Very quickly, one of the reasons I think that the US the conversation is so divisive in the US is that the healthcare system here grew up very different from anywhere else. In the UK, after World War II, there was this recognition that to have a functioning, healthy society, you had to have affordable healthcare. In Australia, we had a purely private system where everybody paid out of their own pocket, which was unaffordable for too many, so we went to a mixed system similar to the Canadian system. In the US is the only place where healthcare is tied to whether you're employed. And therefore, too many people don't understand the true cost of healthcare. Sorry, I'm running through here. Yes, I promise. Again, I don't have any answers for healthcare. I just feel that we, as a society, we have a moral duty to it, and we have an economic duty to keep our society healthy as well, so that we can continue to provide for everybody. Sorry about the scrambling. I should have measured my time better.
Good evening. I'm consuming healthcare this evening, so you'll pardon my 1-900 voice. My name is Connie Bishop. I work at Piedmont Health Services, which is located at corporate offices in Carrboro, but we have clinics here in Alamance County. And I come from the perspective of being a nurse for over 40 years. It seems hard to believe, but it's been 40 years, and various different venues. My clinical background is as a psychiatric nurse, and I do bring that many times to my perspective on healthcare. So when I was asked to participate in this panel, I thought, what can I tell you all from my experience and my opinion about healthcare and healthcare reform? And much like politics is always local, I think healthcare is also always local. So I chose to take a local look from the Alamance County perspective, what we're seeing in healthcare from my clinics, and also what a survey did in 2011 done with Elon and Alamance Regional, the Alamance County Community Health Assessment. Some of you may have participated in that. What our citizens told us are there are 4 things that are critical for them as health priorities. One is access to care. The other is obesity. The other is mental health and substance abuse, and I think a couple of our panelists are going to speak to that. So when I looked at the Healthy Community Assessment, it was clear to me that my clinics, at least as the Director of Quality and Improvement, was working on at least one of those. Well, actually 2, access, but we're in a national program right now to decrease childhood obesity. We have a school-based clinic in association with ABSS, and at our Charles Drew Clinic, we're also in a national study on decreasing obesity. I would be remiss if I did not speak to the issue of elder issues in Alamance County. We have a large elder population. One of them happens to be my mom, who's back there, who's 88 years old, just got her first Kindle today. And she's not consuming a lot of Medicare. She's pretty healthy. But in Alamance County, we have a large group of assisted living, dementia facilities, and believe it or not, when I was looking at some statistics in Alamance, 1/3 of every person in this county will be touched by some sort of dementia or Alzheimer's. Think about that, 1/3. You'll either be a caregiver, you'll either be diagnosed with it. Oh, by the way, every 60 seconds, someone is diagnosed with Alzheimer's in the United States. There is no cure. It's also the 6th leading cause of death in the United States. That's an issue for us as we move forward and how we deal with health care. I'm wearing purple tonight. Mom's got purple on tonight. It's Alzheimer's month in November. It has a special interest for me because my father was diagnosed with Alzheimer's in 2003. The good news is we have wonderful resources here in Alamance, and we should leverage those to do some better things with that. The model of care that I would recommend is what we call a patient-centered medical home, which is what our clinics are doing for community health health care. It's important that we think about expanding Medicaid. I know that's not a popular topic. 75% of my patients are non-insured. I, as a community health center, can continue to give, I'm getting the timeout, as they say in football, can continue to give good care because our community health centers drop $21 million into the county resources. That's a significant amount of money. 3 recommendations. 1, expand Medicaid. 2, in partnership with our school system, tackle childhood obesity with maybe a university partner out there. And the 3rd one is to leverage existing resources for the elderly and include law enforcement as part of our dementia services. Thank you.
Please raise your hand if you've ever been to school. Thank you. You can put your hand down. Now imagine yourself in the school as I describe 2 imaginary students. So picture yourself with them. Meet Ricky. Ricky is a 14-year-old boy in your class. He has had an ear infection for 3 months now. Because Ricky's family has not been able to afford to take him to the doctor, his ear infection is so bad that fluid drains from his ear during class. Needless to say, this is a huge distraction and painful for Ricky. Needless to say, also, Ricky and others have not been able to focus. Now meet Christina. Christina is 15 years old in your class, and she's repeating it for the 2nd time. Many community members believe that Christina has Asperger's, a type of autism, but because of the fees associated with proper diagnosis and the stigmatizations associated with mental health, Christina and her family will not receive mental health care. Though this is the 2nd time around in an English class, Christina's performance has not improved. Now that I've described these 2 students, think about how your learning and their learning would be affected in your class. My name is Kendall Crowther, and I'm a senior here at Elon. Since my first year, I've discovered my passion for education and gained experience working in K-12 classrooms, particularly those with English language learners, students from low socioeconomic status backgrounds, and those in majority minority schools. My point about healthcare is very simple. Without proper healthcare, a student's ability to learn becomes increasingly difficult. I'll say it again. Without proper healthcare, a student's ability to learn becomes increasingly difficult. Just think about it. As a student in the classroom, attentiveness is of utmost importance. However, if finances are a burden to the students' families, physical and mental health care coverage options are severely limited and it can even seem unreachable. Similarly, if healthcare providers see mental health coverage in particular as unnecessary, additional, or optional for families, this furthers the stigmatization society already perpetuates about mental health care being less important or taboo. Just this year in June, the Huffington Post reported research that said Black and Hispanic children, the majority of my students, are half as likely as the majority to be diagnosed with a specific learning difference, attention deficit hyperactivity disorder, or ADHD. Half as likely. Keep in mind that those who are not properly diagnosed with ADHD are specifically connected to poor levels of self-esteem, acting out in class, substance abuse, anxiety, and depression. As you can see, improper healthcare provision begins a cycle of problems, and these are just facts about ADHD. As a future educator, I'm deeply concerned when students can't learn in school as a result of access to quality health care. Every moment in class is critical, and I teach the next doctors, farmers, factory workers, teachers, lawyers, authors, and presidents for our United States. So let's reform health care, and let's ensure that all students can learn.
Good evening. My name is Sue Ellen Dalton, and I'm here as a community advocate and my topic this evening is mental health. We all have mental health issues. I'm sure you can think of yours real quickly right now. Mine is anorexia phobia, fear of being too thin. Just kidding. About 20 years ago, it was estimated that a third of the families in this country had a family member who had a mental health problem. That might be developmental disabilities, it might be alcohol or drugs, it might be mental illness. Now that was 20 years ago. I haven't looked at the current statistics, but with the advent of more diagnoses and more defined diagnoses, I'm sure that's much higher now. If you think about your family and the dynamics of it, I'm sure you can think of someone in your family who has one of those issues. I'm interested in North Carolina health issues from all perspectives, but most currently from the perspective of the thousands of North Carolina residents with developmental disabilities and mental illness who have been cut off from services and assistance by the state of North Carolina. First, the mental health system was dismantled. Then critical positions such as case managers were deleted. Then, more recently, those who do not have the Medicaid waivers, that is the federal Medicaid waivers, who had been getting assistance through the state of North Carolina, had their the things will actually die. These are people who were able to own in the community. They are facing institution or work. With medication, personal, there's a variety of service. Those dropped out of the current mix of service providers whose motives were not always other than profit. Therefore, what do we expect will happen to these individuals? There are no longer independent case managers to assist individuals and families with travel through the minefield that is currently the mental health maze. Agencies such as the ARC are now providers in this mix and therefore are hesitant to be advocates or question the current happenings. I'm a community advocate and am currently assisting 2 people who have been left hanging by the cuts and depletions to the North Carolina system. I cannot seem to get any traction with any agency to move on this. I've tried Cardinal Innovations, the ARC, and the agency, the state agency that handles advocacy and has lawyers called Disability Rights North Carolina. I can tell you it's a merry-go-round of phone calls to persons who cannot help with the actual things that need fixing. I'm personally assisting these 2 persons and who have this lack of service. My family and I spend at least 10 to 15 hours per week either providing or getting needed medical, mental health, or pharmacological assistance. And I want to stop there and thank a couple panel members. ARMC has helped to start an agency that helps people get patient assistance or free medication. That's one thing. And Piedmont Health Services worked out a system so that if you could get free medication from a drug company, they would let you pick it up at their pharmacy for a small fee. So those 2 things have helped with the pharmacological issues that a lot of these people are facing. I did want to mention that. I cannot even imagine what is happening to others with similar needs who have no advocate or whose families have no idea what to do, or those who have no transportation to look into services. Their mental health needs are certainly not being met, so one can assume that their health needs are not being met. I have no idea what will happen to them in the current health care changes. They have no one to help them sign up for anything. Can you please shine a light on the terrible things happening to helpless citizens due to these state changes and cuts? What I would really like to see is more light shined on the mental health issues, the fact that we no longer have a system of care, and that there are many people being seriously hurt by these changes. Thank you.
My name is Miles Grunvald. I'm a senior here at Elon University and will be a first-year medical student at the University of Vermont next fall. I was born and raised in Vermont, a state that consistently ranks as one of the healthiest in the nation, and much of my view that I will present today was informed by my experiences in Vermont and the conditions that allow for a healthy population there. First, I believe that we have a moral duty to provide health care to all citizens of the United States. If we as a nation of individuals believe that everybody has a right to life, then it would go against our beliefs to have people choosing between whether they're going to buy medication or buy groceries, whether they're going to bring their children to the hospital or heat their homes. It's pretty unacceptable. All healthcare systems attempt to solve the teleology of healthcare, curing and treating diseases. If a patient needs a medication or procedure, then there's a chance it will be covered by their provider or the government. Our current healthcare system, however, does not do enough to pursue the etiology of health problems. Diabetes, obesity, heart disease all arise from individuals' lifestyles and have major implications on our healthcare system. A 2001 study by the Health Enhancement Research Organization suggests that 50 to 70% of all healthcare costs could be attributed to lifestyles and aspects such as weight management, smoking, poor nutrition, non-compliance to diabetes and hypercholesterolemia treatments. Any comprehensive healthcare system must address the fact that Americans are living in ways that are unhealthy and unsustainable. These lifestyles are impacting and will continue to impact our society as a whole. Making health a national priority and refocusing discussions on how we can raise healthier children should be considered of the highest importance. Restrictions and incentives for the food and tobacco industry could play a large role in promoting a healthier America. Tobacco use and obesity have wide-ranging implications for our society. 1/3 of cancer deaths can be attributed to tobacco, and another third can be linked to obesity. Smoking and obesity also have strong causative relationships for cardiovascular disease, one of the most expensive areas of our healthcare system. A comprehensive healthcare system will also bring down prices for common preventative screening. So instead of colonoscopies in the United States ranging from $500 to $10,000, depending on one's location, the healthcare system will price these procedures to their actual cost and not to what the markets can pull out of them. So when reforming healthcare, Americans should focus at the root of our problems and the preventative aspects of health. There will always be cancer, chronic disease, and palliative care that will be costly to our country, but by encouraging preventative measures, we can offset the costs and alleviate some of the fiscal burden that comes with the task of trying to secure a healthier America. Thanks.
Hi, my name is Maria Restuccio. I'm a junior economics major with a strong interest in the economic facets of the U.S. and international healthcare systems. I believe that in our country we cannot support a fully privatized healthcare system. I spoke with Dr. Barber about the theory of privatized medical care, and after analyzing this conversation, I believe that we will never allow a healthcare system that denies services to its citizens who cannot pay for their own health insurance. To say that a healthcare system is truly privatized, we must be okay with citizens being denied health care because of their inability to pay, even if this means death. I believe that as a nation, we will not elect officials who will pass reforms that would let patients die because of a lack of insurance to cover emergency treatments. This being said, the next big question is how do we provide a socialized system of health care? Is it fair that I, as a hardworking, healthy taxpayer, have to front the bill for someone who cannot afford their own insurance? Also, what is the overall benefit to society of providing universal health care? Is the healthy workforce worth the extra cost? I see three problems in the setup of our current healthcare model. First, insurance companies operate with the goal of satisfying investors. This gives insurance companies incentive to reject patient care on the grounds of economic benefit to satisfy profit margins, instead of measuring success on the healthiness of its participants. I think it is unethical that businesses and economists alike can price the lives of the sick and injured and then choose who to treat and who should be offered insurance. Second, I don't think that we have a strong system in place to offer health insurance to our citizens. Government programs leave gaps in coverage among citizens, and there seems to be a disparity between the federal and state governments when it comes to paying for health care. Additionally, I don't think it is the responsibility of employers to provide health insurance for their employees. This mandates an extra cost to companies who have to make up this cost either through decreased revenues or cuts in employee pay. Third, I think improvements need to be made into how we finance research and development. Research and development is extremely expensive and is paid for by corporation profits. How do we encourage this research and development without taking funds away from direct patient care? For example, in the pharmaceutical industry, large companies spend billions of dollars a year on staying competitive in the market. However, because of these high costs, they are forced to charge unaffordable prices for prescriptions. Then, after patent expirations, generic companies offer the same medication at affordable levels, increasing access to treatment for sick patients. In this situation, large firms lose their profit that they could have reinvested in finding cures or treatments for other diseases and illnesses. It is important that money be spent on actively treating and preventing sickness, but is it not also equally important to invest in new technology, research, and resources like top management that could improve healthcare in the future? There's no perfect healthcare system, as I'm sure we could all agree, but if we were to realign the goals of maximization of profit and shareholder value to a goal of maximization of patient health, I think the state of our economy and healthcare system would be much better off. I want to see universal healthcare coverage in the U.S. that focuses on patient health first, keeps hospitals, pharmaceutical companies, and research competitive through government funding, and shift insurance from a profit-seeking industry to a social improvement-seeking industry. Thank you.
Hi, my name is Marissa, and I'm a senior sociology major. And I would like to talk a little bit about the commodification of healthcare and the implications that this has for society. And a lot of criticisms that people have concerning the commodification of healthcare is that it's not just healthcare that's being commodified, it's health that's being commodified. And they believe that it's a shame that quality healthcare is granted to individuals who can afford it. And I would just like to state that I also think that, you know, this is a shame, and I do feel guilty every year about the fact that I can afford to go to a dentist or a dermatologist when a lot of people can't even afford basic health care. But I don't think that the view of health as a commodity is anything that's going to go away soon, even under a reformed healthcare system. And I believe that this is largely because the real question is not whether everyone deserves access to basic health care, but what constitutes basic health care. And so why is it a debate over what constitutes basic health care? Basically, I don't think that it's financially realistic to assume that everyone can enjoy the same the same access to health care that the average middle-class American enjoys. And so, although the government may be able to provide health care to everyone, there are going to be limits on either the quality of health care or the extent of health care. And one argument that's often raised about healthcare is that it's a shame that everyone has a basic right to education within the United States, but not everyone has, healthcare isn't considered a basic right. And I think that this is an interesting example because I strongly believe that education is still considered a commodity in the United States. And to a large extent, people who have the means can, provide a higher quality education for their children. And I feel that this is, I feel like healthcare, even if it's universalized, will follow the same suit. And I think whether we like it or not, the U.S. healthcare system is functioning within a capitalist system. And if we really have a problem with the way healthcare is set up, I think we have a larger problem with the capitalist system in general, which kind of speaks to the complex nature of healthcare. So that's it.
Hello, my name is Caitlin and I'm a third-year student at Elon majoring in art and sociology. So what brought me here? I'm interested in mental health like some of our previous panelists. And I'd like to begin my statement by saying I'm by no means an expert on healthcare or healthcare reform, but I am interested in the matter and I think that my opinions can serve well to this conversation. So the absence of mental health in conversation is unacceptable, and clearly this conversation has not been void of mental health discussion, which is wonderful, but on the whole, there is a lack of mental health in conversation surrounding just health in general. So this lack of conversation is paralleled and arguably perpetuated by a lack of educational resources as well as services for individuals with mental illness. According to the National Alliance on Mental Illness, 1 in 4 adults and 1 in 4 people between the ages of 13 and 18 will be diagnosed with a mental illness this year. Of these adults affected, 60% will not receive the care they need. So there's 45.6 million people with mental illness, and 11 million of them won't receive any health care at all. So I recognize that there's people without mental illness that are also suffering because they don't have health insurance, but there's a significant disparity between individuals with mental illness and without, and who's receiving health insurance. The adverse consequences that stem from a lack of health insurance transcend the individual, such that the larger structure of society is harmed. According to the U.S. Department of Justice, 56% of state prisoners, 45% of federal prisoners, and 64% of jail inmates have a mental health disorder. These numbers can be put in perspective by comparing them to the number of people with mental illness in the hospital. The National Institute of Corrections does just this, reporting that there are 3 times more prison inmates than hospital patients with mental illness. So the Patient Protection and Affordable Care Act establishes new regulations for health insurance companies. On paper, these programs offer a lot of great benefits for mental health and people with developmental and intellectual disorders, including, and a lot of this is expanding Medicaid, so more people just have access to this. On paper, the Patient Protection and Affordable Care Act also offers a variety of benefits, including exterminating the lifetime limits of money that can be spent, annual limits, and that's really significant and important. It also offers 10 core services that promises coverage for mental health. It promises coverage for people with substance abuse issues as well. So these are great steps. But as we can see through recent news reports, that a significant amount of people have been dropped by current healthcare providers every day as a result of these changes being implemented. So this healthcare overhaul isn't going particularly smoothly, which is unfortunate. I'd just like to finish by saying that I have yet to determine my personal stance on healthcare and healthcare reform. I do believe that changes need to be made, and I think that some of the changes that are coming are promising, and I look forward to seeing and continuing to discuss and influence how they pan out. Thank you.
Good evening. My name is Jeremy Troxler. Other than about a 10-year stint in Raleigh, North Carolina, to get a bachelor's degree and master's degree in civil engineering, I've been a resident of Elon, Burlington area. I've been married for 13 years. I have 5 children, and right now I'm vice president of a local steel fabrication industry right down Power Line Road here. It pleases me very much to be a part of this forum and to see that there is common ground here. Although we have not yet heard from the invited panelists, it's unanimous thus far among the lay panelists that caring for all humankind is a moral responsibility. I'd like to issue a brief reminder of the foundation upon which moral responsibilities in this nation were established and must be anchored if the actions we are taking are to be reasonable, consistent, and coherent. Our Declaration of Independence states in the opening lines that the rights of life, liberty, and the pursuit of happiness are unalienable among all humankind. The Constitution was written in part to secure the blessing of liberty to ourselves and our posterity. Within the realm of governance, these fundamental principles must remain in the forefront. The establishment of the source of individual liberty is critical when considering the extraordinary freedoms we enjoy in this country. Our freedoms exist within a form, not within chaos. There simply are certain truths upon which these freedoms are based. We are created beings invested with dignity and worth. Our essence is established by a personal creator God. Furthermore, the personal struggles experienced in providing care through a multitude of circumstances from the earliest stages of unique human life in the womb to the compassionate and dignified care for the elderly resonate clearly in the hearts and minds of all American citizens. And so as we consider issues such as individual and employer mandates in the insurance aspect of health care, as an example, we could not be consistent in denying the rights of liberty or violating the moral conscience of one member of our society in an attempt to provide a service to another. All are created equal. As James Madison aptly put it, in framing a government which is to be administered by men over men, the great difficulty lies in this. You must first enable the government to control the governed, and then in the next place, oblige it to control itself. Thomas Jefferson wrote, "No provision in our Constitution ought to be dearer to man than that which protects the rights of conscience against the enterprises of civil authority." As our founders recognized to be self-evidently true, the personal creator God endowed unalienable rights to his creation. As the Almighty said, "Then render to Caesar those things that are Caesar's, and to God the things that are God's." We will continue to wrestle with the entailments of laws we pass relative to health care. As we do, however, may we never confuse those things that belong to government and those things that belong to God. May we fix our gaze on the Creator as we do our best to care for the health of the created. Thank you.
Thank you to our lay panelists. Just another reminder, please use those cards and write down your questions. Great conversations come from great questions, so people will be coming down the aisles to collect some of your questions. Please hold out your card, and please continue to engage with our poll here that's online with your smart device. And now let's turn our attention to our invited panelists, and we'll begin in turn with Mr. Preston Hammock. He is the President and Chief Operating Officer of the Alamance Regional Medical Center, and he'll be followed with Susan Osborne, the Director of the Alamance County Department of Social Services, and then finally Marissa Walsh, who is a Health and Human Performance Senior Lecturer here at Elon. Preston, please.
Great, thank you, Dr. Gaither. First, let me just take the opportunity to say thank you to Elon University and the Times News for putting on this forum, and for everyone here that's spending your time talking about an issue that's very important. I believe it was Ms. Stover that said, my opinion served me well to this conversation, and I believe that's absolutely true. Healthcare is something that deeply affects each one of us on a personal level with our families, and in many cases those needs overlap, as many of our panelists pointed out already, the contributions we make to society and how we all interact and work in this world together. I'm excited here to participate in this discussion as well along the concept of healthcare redesign. And I think we should look at it from a redesign standpoint instead of reform, which I'll mention in just a moment. But I got into healthcare because, ironically enough, I found the problems to be very difficult to solve. And I was excited by that because it also has tremendous opportunity for grand success and the impact we can make on everyone's lives in this community. So that difficult, challenging problem is something that got me here. Although over the past month that I've been in this role, I've learned quickly, sometimes you're careful what you ask for. I think redesign is important instead of reform simply because of what the two words evoke, in my opinion. You think of reform. Unfortunately, at this point, it's become very politicized and can evoke all sorts of internal feelings and discussions and decisions and statements. From a redesign standpoint, I think that really centers on what we're here to try to do. If you think in terms of redesigning something, it really forces us all to think, ask, learn, and even lead in new and meaningful ways. And to me, that's what healthcare is really hungry for at the moment. As you've heard many of the panelists talk about earlier, this concept of basic healthcare needs. We talk about basic needs, access, coverage, emergency. We don't always probe into the definitions of what those words mean. We've understood that already, it's been pointed out, education, family history, socioeconomic status, sex, gender, healthcare access, all those elements, they're all connected to healthcare outcomes in some way and have been linked scientifically. What this means is that in terms of basic care, many times what we offer to have truly impact has to go beyond what we traditionally have thought of as healthcare. We've also talked about how our system is the result of many unintended consequences and how we got to the point that is here and what that means from a payment standpoint. It's also been that way from a delivery piece. So take, for example, the hospital. So I came to Burlington to work at Alamance Regional because I felt like this community hospital truly acted like a community hospital. Forwarded some programs like Alamance that's been referenced earlier, worked with the Open Door Clinic, partnered with local agencies to really try to think outside the walls. But yet, when we sit down to do strategic planning in years past, as a vestige of what we're incentivized to do, there's more payment for higher acuity procedures, for intense imaging procedures, for expensive medication therapy, for acute hospital stays. So when we sit to start thinking and planning, we look at our population of patients we serve and how can we get more people into the hospital? That's ultimately have been the question as we've planned. Well, that's changing, and that's why I think there's an opportunity for a base for this conversation. Because to be honest with you, we spend too much money on healthcare in this country. That's why we're here. The most expensive place to get care is a hospital. So the equation is pretty simple. To fix this, we got to keep people out of the hospital. This is something that I embrace. If you look at our mission is to improve the healthcare in this community. It's not to keep people in the hospital doors. So while that may be not how I'm programmed or wired in terms of my own training and background, it's clearly what the society needs. And I'm excited about that because we've talked a lot about Medicare. We've talked a lot about the political reforms and payment reforms and how much we're talking about healthcare delivery redesign as well. Because, listen, it's not just Medicare. What we have is some healthcare expenses for private companies that provide those benefits have also ballooned, and they've had to make adjustments in order to adapt. So just a few companies, Pepsi, Boeing, Walmart, these are companies that have all directly contracted with healthcare providers across the country and are sending their employees to travel, in some cases all the way across the country, for heart procedures at no cost out of their pocket because they've been able to directly contract with that provider for a lower cost and have clinical outcomes that outpace many other facilities in the country. And why that's encouraging is because for the first time, really, as we've had this discussion, the share of information is so much more than what we've had even 10 years ago. Access to information around what cost truly means. These companies didn't contract with these other providers simply because they trusted them or they felt good, or what in some ways may be the traditional sense in how we determine our healthcare provider. Word of mouth, who do we hear, who do we trust, what do our neighbors say, what do our families say. It's actual evidence-based outcomes, and it's publicly available, and it's in many cases way deeper than you really need to go to really understand. Some of the metrics are still pretty arcane. But that's what makes me interested because, honestly, that's the type of information that can truly facilitate coordination of care. So it's the thought of thinking beyond the walls of what we traditionally have seen in healthcare and taking a patient-centered focus instead of a facility or hospital-centered focus. A great example is the Triad Healthcare Network, which is an accountable care organization based in Greensboro that was fostered by the Cone Health Network. They put together this notion of we can take total care of the patient and let's have a patient-focused sense of medical records and treatment plans. As an example, they had a patient that they discovered that they wouldn't have without this structure that had been to the emergency department over 130 times in the past 12 months. This is a tremendous cost to the system, and in many cases may lead you to conclude, well, this is an example of what basic health, if it's defined as emergency services, really means. But instead, they sent a care manager to the house of the patient. What they found was this patient was wheelchair bound but had lived in a home with no ramp access. Patient was dependent on insulin, which requires refrigeration, yet had no refrigerator. There's a couple other issues, but those are the most significant ones pointed out because they partnered with local agencies, had a ramp built, got the patient a working refrigerator, signed her up for the medication delivery service that we've talked about, and in the past year, the patient has not been back to the ED once. Now, this patient was covered by Medicare, so in the traditional view from a hospital standpoint, every time that patient came to the emergency department, we would have gotten paid something from Medicare. But it is absolutely the right thing to do, to have that patient live a much more full life at home and contribute meaningfully to society. So it's that patient-centric care that I think is really important and what I find encouraging in this debate. And I think the biggest thing to take away from that is the commonalities in all the panelists and in the story I just told. And it's the notion that to do that effectively, we have to partner effectively. And that means healthcare entities partnering with social entities, religious entities, governmental entities to try to better coordinate that care so that we start to get some of those incentives aligned. And we're not there where we need to be yet, but I think if we can keep that focus in front of us, and if we can keep dialogues like this going, every partnership started with a discussion. And I think that's what's exciting about where we're headed in healthcare.
Well, good evening. I'm Susan Osborne, and I'm the Director of Social Services in Alamance County. So many themes that the panelists have discussed tonight are near and dear to my heart, and also part of the work that my agency does in this community. I think the 24 years I've been in social services here in Alamance County is one of the reasons I was asked to be a panelist tonight. And so I want to talk a little bit about how the social services system fits into this discussion. I want to talk about three different things. I want to talk a little bit about Medicaid because that is a large player in this system. Medicaid in North Carolina is well over $13 billion in this discussion of health care. I have a deep concern for mental health services, as many of our panelists also have. And I want to talk a little bit about how Medicaid and our insurance system impacts that, and then discuss a little bit the role of poverty in all this. So first, I think it's really important for me to dispel what I think is probably a common myth around Medicaid in North Carolina. If you are an adult in North Carolina, if you are childless, if you are non-disabled and non-elderly, you do not qualify for Medicaid. You cannot qualify for Medicaid. A lot of folks feel like misunderstand this, and so you have no health insurance options. So this leaves many, many folks in our community uninsured. I had lunch with our health director today, and we were discussing this topic, and a gentleman stopped by my table and he said, I heard you talking about Medicaid, and it sounded like you were saying that anybody can get Medicaid. And he said, and I'm here to tell you, you can't. He said, I'm a 50-year-old man, I'm unemployed, I have a heart problem, and I can't get Medicaid. You've turned me down, and I can't get it. And if it were not for the Open Door Clinic and Alamance, I wouldn't have my heart medication on a regular basis. The Kaiser family indicates that currently in North Carolina, only 30% of low-income adults are covered by Medicaid. So while medical care is an important part of Medicaid, probably one of the largest, most important components of Medicaid for adults is mental health services. We in North Carolina are critically limited by some of the decisions that have been made to not expand Medicaid to our adults who are in need. When I think about, we all think about the mass shootings that have taken place across this country, and we think about Aurora and Sandy Hook and the Naval Yard, we all know that these are young folks, and we know now that most of them had mental health illnesses. When I think about in our system in North Carolina, those folks probably wouldn't have medical access. If you don't have insurance, you just can't go get mental health treatment and ongoing care. I think if I had to identify a number one failure of our healthcare system, it would be in that arena. Currently in Alamance County, we have 26,000 uninsured people in Alamance County. Of those, about 11,000 will be eligible for the new marketplace, and we're looking forward to those folks having coverage and having some navigators and counselors to help them navigate that as soon as that website's up and running. And then we have another 11,000 folks that would have been low-income folks that would have been eligible for expanded Medicaid that won't have that. Kind of a unique situation in North Carolina is that those folks who would have been eligible for expanded Medicaid that aren't eligible also are not going to be eligible for subsidy. So they fall into this crack that was an unintended consequence. They were intended to be covered with the Medicaid expansion, but with the Supreme Court ruling that states did not have to expand, then these folks won't be eligible for subsidy, so they'll have to buy insurance off the regular market without any subsidy. I think it's probably important for you to know that in Alamance County, about 16% of our population live below the poverty level, and about 26% of our children are living at the poverty level. Poverty level for a family of 4 is less than $2,000 a month, and that's the level we're talking about. There are currently in Alamance County 26,000 adults and children on Medicaid, and there are about 3,000 children on the state plan of health choice. These are low-income, disabled adults, elderly, and children. I think Miles made a good point earlier when he talked about should our citizens be choosing between food, heat, medication, health care? Those things we're faced with every day at your local Department of Social Services. We have families who turn off the heat. We have families who need insulin or heart medication that have to make decisions about food or heat. Healthcare, even insured folks have to struggle with deductibles and co-insurances. And I think to one of the earlier panelists, the question, does this country have a moral responsibility to provide basic health care? I think that's one thing we need to decide. In wrapping it up, I thought about, so we have Medicare for our seniors. Why do we have Medicare in this discussion? So I did some looking up, not WikiLeaks, but Wikipedia. And so in 1966, Medicare was created, and it was created as a social insurance program that guaranteed access to health insurance regardless of a medical history or income. And so it was created, according to Wikipedia, because only half of the elderly people in our country had access or could afford health insurance. It's something I think we should think about in this debate. I appreciate the opportunity to be here, and it's a spirited debate. It's a good debate. I don't have solutions, but I think this conversation highlights some of the questions we ought to be talking about. Thank you.
Tom, I'm going to do something that's very hard for a teacher to do. I'm going to cut mine short because I want to make sure we have time for the audience to respond. And so many of the data points and information I had planned to share, it's already been shared. So I'm going to go straight to what 3 of my students told me to do on a stormy Friday afternoon. When they met with me, when I was trying to prepare my remarks, they said, don't forget to tell us what you really believe. So this is for Maddie, Josephine, and Lindsay. I'm going to just let go of the data because I think enough of it's been shared. I believe health is the result of individual behavior, genetics, a community in which we live, and policies and practices of our systems. I believe healthcare reform will lead to further healthcare redesign. I love that language. Thank you. We have to start somewhere with healthcare reform or redesign, but we must never lose sight that health is much more than that. It is a complexity of various factors that impact all of us. We're here to discuss healthcare reform, but it's only one piece of a complicated picture. Inequalities, income inequalities, are directly linked to lack of coverage and poor health outcomes. If this health care reform gets us started on the pathway of much stronger prevention, it does redesign who we are and what our outcomes will be. And what a privilege that would be for all Americans if prevention was the #1 priority and we made prevention accessible to all of our citizens. I'm going to skip the next page altogether. If you are a woman, this health care reform or health care redesign broadens the range of services that must be covered without a copay. No more pre-existing conditions like, can you imagine pregnancy, depression, and domestic violence being pre-existing conditions? We won't have that now. Your OBGYN can be your primary provider without a referral. Equitable insurance pricing in individual markets and new marketplaces, no more gender rating. All of that to me is not just reform, it's redesign going in the right direction. And certainly we're going to be looking more and more at the uninsured and the under 30 who might have a catastrophic event that could predict financial outcomes for the rest of their lives. I was one of those people 20 or 30 40 years ago. I think it's great that finally not only can we ensure that our young people can stay on their parents' insurance for longer, but if you're under 30, you can have better access so that you can avoid a catastrophic event. I was on my own working 2 part-time jobs trying to make my way through college, and there were 2 years when I was uninsured. My mother called me every day, don't fall down today, don't have an accident today, are you going to be okay? She's also the woman that called me on my cell phone while I was driving to work and said, don't talk on your cell phone while you're driving to work. She always had my best interest at heart, but she and I both for a couple of years we were vulnerable because I wasn't insured and I was young and had no way to do that. I think this reform and redesign leads us in the right direction for those folks. I believe any major piece of legislation throughout the history of our great country that's helped shape who we are today, civil rights legislation, voter rights, Medicaid, Social Security, health reform, and education reform, have all met with bumps in the road and a backlash. And we did what a democratic society does best. We darn well figured it out. We've had presidential elections, a Supreme Court decision that says this particular law does meet what we think our Constitution is about, and we've had a major campaign to repeal the law. Public opinion still holds steady. 44% view the law as unfavorable, 38% is favorable, and 18% don't know. We will know soon, but the majority of Americans still oppose defunding the health care reform. The uninsured say, I don't have enough information to know. Yep, they didn't get it right when they rolled it out. That's for sure. We're going to have to extend what we said we would do in a short amount of time. But I think it's time to change the fight from repeal to what's best for implementation, and knowing, as we've known throughout American society, that we will have to tweak and fine-tune, and it will make all of us better and stronger. We've been debating this for 25 years. It is our time, and we must come together as communities through good evidence-based information, health promotion, and prevention techniques to implement health care reform that allows for much greater access to prevention and intervention. This is a start. We have to make changes, and it is my fondest hope that 10 years from now, well, actually 10 years from now, I hope I'm out there retired, but if I'm still teaching a course at Elon University on personal health, which I teach now, here's what I hope I will be teaching. We did it. Healthcare reform led to healthcare redesign. It led to stronger prevention for the communities that are at greatest risk. More college students chose to go into health promotion and public health. More Americans realized the difference that a small change in my behavior today can equal a big change in my overall health outcomes. I hope I can teach that we decreased chronic disease, decreased health disparities, and increased our world ranking because it's embarrassingly low among other countries like us. So yes, I'm optimistic. We've got the law. The implementation's going to have some bumps in the road. We are good, smart people. We can figure it out. And as a democratic society, I do believe 10 years from now, I will be teaching my students we got it right. Thank you.
Thank you to all our panelists, and we have some questions we can now use to start some brief discussion, and it's still not too late to get involved with our polling here online or to fill out a note card. So if you still have a burning question, it's not too late. Please write on that note card and distribute it with people who are walking down the aisles. So as I look through all the comments that came to me, obviously we can't go through each one of them. A few themes emerged, and one of the big ones was the role of the government. How much government intervention or involvement should be brought to bear in this discussion of healthcare. Another one had to do with questions about education as it relates to the Affordable Care Act, questions about patient rights and privileges. And finally, another key theme was the issue of privatization and whether the invisible hand still works as it relates to the marketplace. But let's go back to this question of the government, because I think from all of our invited panelists, they all touched on what the government intervention or role should look like ideally. So I'd like to begin with Preston by asking what responsibility does the government have in deciding healthcare policy and forming that policy? And you specifically mentioned the importance of partnerships. So can you tell us two questions here? One, what ideally should those partnerships look like? And secondly, what do you believe the role of government should be ideally? And then we'll take that latter question and ask our other two invited panelists to respond as well. So what do you think?
So I think that's an interesting question, because I like the connection that was made about reform leading to redesign, because I think that's what's happening at the moment. You know, the government reform piece is really the government acting as a payer. It's acting as a really big insurance company, and they're spending too much, and how can we get it back in the road? And so that's where it started from. How can we begin to ratchet back down? How much are we really going to be able to spend? It has led to some really interesting discussions. So when Medicare decided to add penalties for patients who were readmitted within 30 days, under the argument of if you have to go back within 30 days, you didn't receive good care, that began to create an incentive that the healthcare agencies were then forced to look at, okay, how do we look at that? So on the one hand, government plays a significant role through that design to really impact. There is a need for change, and there is a need for change, and we have the ability as a government to coalesce a lot of the ideas and evidence that's out there. So let us direct you into the area where it needs to be. So I think there's a big piece there, and a lot of what the payment reform systems that's happened from Medicare has started to incentivize that. So I think the government can, in many ways, catalyze the healthcare providers to begin thinking and working in a different way. You take the financial incentive away, suddenly you are very creative as to how you correct that. So I think that's a huge role. However, there's also an element to be played moving forward, and that's what role does the government sort of beyond traditional providing of health care. And that's the notion, I think one of the panelists mentioned, being from Vermont, and Vermont has lots of physical activity. There's lots of elements in terms of governmental planning, city planning, how walkable is your town, what do you do to enhance education, the connection between education and healthcare is significant. What do you do to enhance physical activity? What sort of policies do you look at in terms of smoking and the type of food that's offered in the community, access to organic and locally grown, all of which were referenced by panelists. So I think the government can play a role as a catalyst and also as a support partner as the solutions are implemented. And to me, that's the ideal.
Okay. Thank you. Susan.
Sure. I do think also that the government has a role in this change process. We're seeing it with our governor right now and the redesign of Medicaid. We're seeing a movement to partnership in our community. They recently put out an RFI requesting information on redesign from community citizens, from folks in the profession. And so I really think the government can have a leadership role in redesigning our state plan around our Medicaid services and the things that are paid for in the government payer system.
Thank you.
Just echo what the others have said. There's plenty of evidence to show community partnerships work. So I think one role of the government is to provide incentives for more of those. They're evidence-based. We know they work. We need more of them.
One of the questions is, what exactly constitutes basic health care? Does everyone use the same definition? And I'd like to add on to that just a little bit, because mental health issues have been raised by so many of our panelists. If we consider mental health issues, do they fit into basic health care? And what exactly constitutes basic health care? And let's begin with Professor Walsh at the end. Would you like to take a stab at this concept of basic health care?
Well, I'll go back to the way I started, that I believe, first of all, we got to figure out how do we define health and how do we define wellness, and it changes. It's a dynamic definition. So I'm not so sure we can reach a conclusion on that, but I think we can reach a conclusion on basic access to health care. And I think beyond that might be very difficult, but I think that's where we're headed. What is fundamentally appropriate for a society like us in terms of providing basic access to health care and prevention? But I do want to mention, how can we not include mental health? In 20 years, major depression is predicted to be the leading disorder in the world. So how can we not make mental health an essential piece of where we're headed with redesign and reform?
Thank you.
I think the basic health care package, as one of our panelists talked about, involving primary care homes so that folks have a place for their primary care, for their basic health care. I think that model really incorporates a more holistic approach and is a very economical and defines a basic care package. And so I would support that model.
Yeah, I think the notion of basic health care does mean something different to everybody. And I think it is kind of widely accepted that perhaps that access to a primary care physician on a regular basis, or some sort of access that's regular. When I think of primary, basic care, who does a really good job basic care is dentistry. So, I get how many reminder cards about my 6-month checkup. It becomes something that's very proactive. I need to see you so that we catch some things before they get too crazy. I think healthcare is still sort of programmed, call me if you need me, and at that point in the game, we're a step behind. So basic healthcare, in my opinion, to be really effective, has to be more proactive than reactive.
Thank you.
Can I add one more thing?
Please.
We are including more things in that basic healthcare model now. Here in Alamance County, we're participating in a grant project that allows for there to be some social, emotional, mental health screening done at a well baby check. So that we are identifying problems earlier and we're getting services. So I really think as we can package more into that, we're better off.
Thank you. Well, we are out of time. So we have just scratched the surface of some very topical and important issues, and we hope that you will join us next doors. Right over here, we have snacks and beverages. Please join us to continue these discussions. Thank you for coming this evening, and thank you to all of our panelists.
We're going to take a quick break, but when we come back, we will recap some of the topics from tonight's panel. We'll be right back.
What was that?
The healthcare reform panel is still going on. You're watching a live feed as people gather in McKinnon Hall.
We're going to take a quick break like we just said, but when we come back, we're going to be recapping what we heard both from the students and community panelists and from the people that were brought in here tonight. There's a lot to discuss. A lot of different things were brought up. Stick with us. We'll be right back.
Welcome back to Elon Local News' live coverage of the Community Connections Healthcare Reform Panel.
So let's talk a little bit about what we just heard. We're going to talk especially about that first part, the student members, the community members that were there tonight. Nicole, one of the things that I noticed that wasn't talked about, kind of this thing that we talked about a lot going into this, there was not much mention about Obamacare at all.
I know, you're right. I think a lot of people are more concerned, or seem to be more concerned, with how things are happening in North Carolina, especially one student. I believe her name was Kendall Crowther. She works in classrooms with minority students right here in Alamance County, and she was saying that healthcare needs to be more focused on how we can create better healthcare for young people, so that way education overall.
And education was a big topic. Dr. Archinal, Kendall, also Connie Bishop, they all talked about education. It was kind of interesting to hear, Dr. Archinal almost compared the healthcare issue to the same issue that people have with education and said, why would you look at education one way and not look at healthcare another way? Whereas Kendall Crowther seemed to almost say, correct me if I'm wrong, but she seemed to be saying that without good healthcare, you can't have good education, which was kind of shocking to hear someone make that claim there. The other interesting thing was there was a lot of pro-healthcare talk, a lot of pro-healthcare numbers, but not a lot of anti-healthcare. Did you get that feel too?
I did get that. One person who stood out to me who seemed to be against the current system was Marissa. She's a student, and she specifically said that we do not have a strong system. She believes there are too many gaps and too much disparity for people receiving healthcare. And she said also specifically that it's not the responsibility, or it should not be the responsibility, of employers to provide healthcare, which is the current system that we have. So it's very interesting that she's against that.
It seemed like there was this divide. I think Marissa Rurka said it well. She called it the commodification of healthcare. And to explain that, if the viewers don't know exactly what that means, I didn't myself. It basically means, you look at healthcare as a commodity, as something that can be bought, sold, earned, exchanged, whereas a lot of the other people on the other side were saying it's something deserved or that belongs to people. But we're actually going to go to Joe Bruno right now, I think?
Absolutely.
Joe Bruno's, sorry, go ahead.
Oh, thank you. He's still in McKinnon Hall, just wrapping up some information, and he's out in McKinnon. Joe, what's going on over there right now? Thank you, Joe, but the debate does not have to end here. Currently, there are students that are talking about, there's a reception, and students are talking about the event, and they're encouraged to share their opinions in an informal setting in the Fireside Lounge. And I believe that is all we have for the show tonight.
That is all we have for Elon Local News' special broadcast tonight. But for more information and for a wrap-up of what happened here tonight, make sure you follow us on Twitter at Elon Local News and like Elon Local News on Facebook.
And tune in to ELN Morning tomorrow at 9:50 right here on Channel 5.
Thanks for watching and have a great night, Elon.